Good afternoon, everyone. On behalf of the New York State Council Education and Professional Development Committee, along in conjunction with Clinical Education Initiative, we bring to you today's webinar entitled Medical Marijuana, Exploring New Clinical Options in New York State, presented by Dr. Jessica Robinson Papp. If you have any questions during the presentation, feel free to use the Q&A function at any time. After the presentation, I'll moderate, if time permitted, the questions to Dr. Robinson Papp. You also see the instructions here for claiming CE. A code and an email will be given to you by the end of this week. If you do not receive an email, please contact the office and we'll make sure to get that email to you. Our speaker today is Dr. Jessica Robinson Papp. She's a practicing neurologist and clinical researcher. She studies chronic pain, judicious opioid prescribing, and the neurologic complications of HIV during autonomic neuropathy and HIV-associated neurocognitive disorder. She is the director of the Mount Sinai Neuro HIV program and Autonomic Laboratory. She is also the senior attending neurologist for the Institute of Advanced Medicine, where she provides neurologic care to people living with HIV and oversees pain management services. In addition, Dr. Robinson Papp performs electromyography, or EMG, autonomic testing, and intraoperative neurologic monitoring to aid in the diagnosis of neurologic disorders. Please join me in welcoming Dr. Robinson Papp, and I'll turn it over to you.
Thank you so much, Sean, and thanks so much for the invitation. I have no disclosures relevant to this topic. So today we're going to be focusing on the use of medical marijuana in New York State, and these are our 3 learning objectives. We're going to just describe the landscape first generally, talk about the available forms of medical marijuana and what they might be used for, and then we'll focus a little more specifically on the use of medical marijuana for people living with HIV, but also touch on some other indications as well. So I like to just start out with this slide because there's a lot of terminology that can sometimes be pretty loose around medical marijuana and cannabis. So just to get us all on the same page, cannabis is one of the oldest cultivated plants, and cannabis is the botanical name for the plant itself. But there are 2 main varieties that have 2 generally different uses, hemp and marijuana. So hemp and marijuana are both forms of cannabis, but marijuana is used for recreational and medicinal purposes and has 2 main active components, both of which are cannabinoids, and that's THC, which is the psychoactive component, and CBD. Hemp, by definition, is any cannabis plant that has a very low concentration of THC, and this has been set somewhat arbitrarily by the federal government as 0.3%. All other cannabis is, by definition, marijuana. So although individual cannabis plants may be bred to either be hemp or as marijuana, that distinction just depends really on the concentration of THC. Hemp has been around for a long time and has many industrial uses. It's been used traditionally for rope, clothes, and it's also used sometimes for food items. You might see items in your health food store like hemp-derived non-dairy milks and things of that nature. But potentially medicinal cannabis-related products are a whole variety of other kinds of products. And again, the nomenclature is a little confusing here. People use the term medical marijuana to refer to a lot of different things. And really the definition of it varies state by state, depending on what the state has legalized and is referring to as medical marijuana in their state law. Sometimes it can be marijuana itself, just in its raw plant form. And sometimes it has to be a product that is manufactured out of the marijuana. We also have CBD products available nationally, and this is more uniform across our nation. And those are all made from hemp, and I'll get into that in more detail. And then sometimes people also refer to pharmaceutically manufactured cannabinoids as medical marijuana, even though they're technically not really. And we have some synthetic ones. So for example, dronabinol or Marinol is a synthetically manufactured THC that's FDA approved. We also now have an FDA approved product that's derived from a natural plant form of marijuana, and I'll talk about that a bit later as well. I always like to add this last point that sometimes when people refer to synthetic cannabinoids or synthetic marijuana or fake marijuana, They are also referring to things that are unregulated that are manufactured drugs of abuse, so street drugs that are not necessarily related to cannabinoids at all. They're just different kinds of chemicals that have various kinds of psychoactive effects that people use recreationally. And they have no medicinal purpose and in fact have a lot of harmful side effects. And sometimes these have been referred to by different brand names such as Spice and K2, which you may have heard of. Marijuana has been used as medicine for many, many years, thousands of years really, and its origin probably dates back to ancient Egypt. There are references to it as far back as 2350, and it's BC, and it's been present in multiple cultures and multiple different eras. And here are just two examples of texts that have referred to marijuana for a medical purpose. In 1700 BC, one text referred to it as a treatment for the eyes, that it should be ground up and left in dew and then applied to the eyes. And then in 1640 AD in Europe, it was referred to as a treatment for pain and for joint inflammation, which is quite similar to some of the uses for which it has today. I also like this quote because it refers to extracting the contents of the marijuana by using oil or butter. And those are some very early medicinal chemists who knew that the cannabinoids were hydrophobic. And so to get them out, you have to use a substance such as oil or butter. And here on the side, we have all different kinds of languages in which medical marijuana or marijuana has been written in different ways. So marijuana and the cannabis product have a colorful history in our nation, in the US. In early colonial times, from the 1600s to the 1890s, the production of cannabis was encouraged because the hemp, the fibers of the product were very useful for making ropes for sailing and also for making clothes. And the marijuana part was an ingredient in many medicinal products. So this was an unregulated industry until 1906, when the Pure Food and Drug Act came along and required the labeling of products containing marijuana. So this was the very first time it was regulated. Then these regulations gained intensity in the 1930s, and there was an anti-marijuana propaganda campaign. Some of you may be familiar with or have seen this propaganda movie from the 1930s called Reefer Madness, which describes all the bad things that can happen to you if you smoke marijuana. This intensified then in the 1970s with the Controlled Substance Act. This was very important because this was the time at which marijuana was designated a Schedule I controlled substance. So Schedule I controlled substance is a drug with no currently accepted medical use and a high potential for abuse. So sort of the most dangerous kinds of drugs are Schedule I. So heroin is a Schedule I controlled substance. Even cocaine is not a Schedule I controlled substance. I believe it's Schedule II. So it was really kind of put up there with major drugs of abuse and harm. And this was maybe perhaps exacerbated in the 1980s with the war on drugs and the 3 strikes you're out policy, which allowed people who had any 3 sentences, including drug offenses, to be sentenced for life. This then began to loosen up a little in the 1990s, which saw the first legalization of medicinal use for marijuana, which was in California. Then there was some recreational use in this century, 2012, the first one. And then 2014 was an interesting year in that a law was passed which barred the Department of Justice from spending any money to interfere with state medical cannabis laws. This is important because medical marijuana, or any kind of marijuana for that matter, remained federally illegal as the states were acting one by one to liberalize their own laws. So state law was and continues to be in conflict with federal law, but the federal government said in 2014, we're not going to prosecute you and we're going to prevent funds from being used to prosecute you in the states. Now, this was a peculiar kind of law that was passed in that it had to be reenacted from time to time. So the status of this law is actually unclear, although there has not been precedent for federal officials prosecuting state medical cannabis laws as of yet. In 2018 was the last big change, and this was the Farm Bill, which there's a Farm Bill every year. It is mostly a budgetary item, but included in the 2018 Farm Bill was the provision that any CBD product, so that's the cannabinoid that is not psychoactive, that is made out of hemp as opposed to a marijuana plant, is now going to be federally legal. So this sparked a huge growth in the CBD industry and was around the time that we started seeing CBD everywhere. You know, you go into your local CVS, you see like a CBD cream that you can rub on your elbows. This happened in 2018 because of that change in federal law. So the state laws are still confusing. They vary state by state. Every state has chosen to do this differently. This is a map. It's already rather out of date. They kind of change constantly, but it shows how each state has legalized differently. So on the West Coast, you see the darker green colors where recreational and medical marijuana were both legalized. Then in sort of the medium green were states, including New York up until this past year, that had just medical. And then the green states being states that just had CBD. So what are the active ingredients in medical marijuana and why might it be a medicinal product? Well, it's been studied significantly, although there's still a lot that we don't know. We do know that marijuana contains over 400 different chemical entities, and about 60 or more of those are considered cannabinoid compounds. And the cannabinoid compound just refers to the general structure of the compound. So you can see here it has a ring structure as such. There are 4 major cannabinoid compounds, and then 2 of those, THC and CBD, are the ones that we focus on most and we know the most about. So I'll talk just about those 2 throughout the rest of our time. They are different. THC has the major psychoactive effects. It causes people to be hypoactive. It can cause hypothermia, some short-term memory impairment, so it's generally kind of sedating. And CBD does not have these psychoactive effects on its own, although it may potentiate, it's possible that it potentiates the psychoactive effects of THC. There are also those other 400 plus chemical entities that are in there as well, and those are referred to as entourage compounds. So they're things that kind of come along for the ride. And they fall into 2 major chemical classes, which are the terpenes and the flavonoids. And I'll speak about those a little more in a minute. This is a helpful review article that was published in 2012 that sort of talks about and breaks down the difference between THC and CBD. So the reason that THC and CBD have different effects on the body is that they interact with different cannabinoid receptors. So CBD interacts more with the, or CB1, I should say, sorry. THC interacts more with the cannabinoid 1 receptor, and the cannabinoid 1 receptor is more expressed in the brain. And so that accounts for its CNS effects of sedation, whereas CBD interacts more with both of the receptors in a kind of balanced way. It doesn't have this kind of predominant CB1 effect. You can see some of the other differences here. Both are thought to have a bit of an anti-inflammatory effect. CBD has a strong anticonvulsant effect that is not seen necessarily with THC. It's probably also more of an anxiolytic, whereas THC can cause anxiety sometimes. And then there are the GI effects, which are strong in terms of antiemetic and appetite stimulation. And those are probably a little stronger with THC than with CBD. What about the entourage compounds? So we don't know a lot about these compounds and what they do. It's a big part of marijuana marketing, particularly in states that have active recreational programs, to say that certain kinds of entourage chemicals will affect the way the medical marijuana affects the body, and so determine whether a particular strain is good for one indication or another. This may be true, it may not be true, we just don't have enough evidence one way or another to know. But the main thing that they refer to in these sort of marketing type materials are terpenes, which is just a general class of chemical that's present in lots of different kinds of plants, including cannabis. They are aromatic compounds. Their original purpose is to attract pollinators and to deter predators. And really any kind, most essential oils that you might encounter are different kinds of terpenes, and they fall into different classes. And they are the ones that the marijuana industry mainly uses to kind of advertise one marijuana as being different from another based on its terpene profile. So I alluded to these 2 kinds of receptors, the cannabinoid receptor number 1 and 2. These we've been aware of these since the early 1980s in early research then and in the 1990s. As I said, the cannabinoid receptor number 1 is widely expressed in the nervous system, particularly the central nervous system and the brain. And the CB2 receptor is more broadly expressed. There's a lot of interest in this receptor because it's present on a lot of immune cells and immune organs like the spleen and in the gut-associated lymphoid tissue in the GI system. And so it's thought that maybe this second receptor has something to do with some of the anti-inflammatory effects that marijuana may have. We have two main endogenous endocannabinoids, so cannabinoids that are produced by our own bodies. And then the cannabinoids that come out of plants are referred to as phytocannabinoids. So where are we with marijuana law in New York State? So the original legislation that legalized medical marijuana was enacted in 2014, and I'll tell you about that law in the next slide. But just as most of you probably are aware, just this past year, legislation was signed legalizing adult use cannabis recreationally. And this was the New York State Cannabis, Marijuana Regulation and Taxation Act. This is kind of an interesting piece of legislation. It established the Office of Cannabis Management, which is going to oversee all of the recreational cannabis process in New York State, but is also going to take over the medical marijuana program. Previously, up until now, the medical marijuana program was under the Department of Health. And this transition has started already. It was started last month. It also, the new law also was going to expand the list of indications for which medical marijuana was allowed. Currently, that's a finite list, and I'll tell you what those indications are. And it also had this sort of social justice bent to it in that the taxation structure, so the money that was going to come into the state from taxing the sale of recreational marijuana was going to be specifically allocated to certain areas, including education and reinvesting in communities that had been harmed by policing practices related to marijuana in previous years, and then also to treatment of substance use disorders. Another interesting part of this law was that they proposed to expunge or resentence people who were convicted of marijuana-related crimes that would now not be a crime under the new law. So although these laws were passed earlier this year, the program itself is still being developed. And so how the Office of Cannabis Management is going to exactly run and what all the procedures are going to be is yet to be worked out. And so our medical marijuana program still stands as it did before the enactment of the new law for recreational cannabis. So we'll see. I'm sure there'll be a lot of changes to this, in the coming months and years, but this is how it is. This is how it's been over the past several years and how it is right now. And so this all began in 2014 with the Compassionate Care Act. As I've mentioned before, this was a state enacted law, and so it is technically in conflict with federal law, for which still says that marijuana is a Schedule I controlled substance with no approved or acknowledged medical use, according to the federal government. It was legalized in New York State only in a pharmaceutical form and not in its original sort of plant-like form. So for many years in our dispensaries, we didn't see anything that looked green. This is changing now, and I'll show you some of the newer forms that are sort of more natural and less processed. Smoking was not a legal form of medical marijuana administration, although it was decriminalized. The early forms you couldn't smoke. The newer forms, I imagine many patients do in fact smoke, although technically that's not an approved way of taking medical marijuana. Providers who want to be part of the program and recommend medical marijuana to their patients have to go through a training process, and this is all available online. As of October of this year, the people who can recommend medical marijuana have been expanded. It used to be MDs, DOs, NPs, and PAs. Now it's expanded to all licensed providers, so that includes dentists, podiatrists, and midwives. But prescribing, or more technically recommending, of medical marijuana should occur as part of a clinical relationship, according to this original law. So it shouldn't be like a doc in a box kind of situation where the person comes in, they're just given this prescription and that's it. It should be part of a regular kind of ongoing therapeutic relationship. There are several different online trainings that providers go through. They range in cost from about $169 up to $229. You can do a 2-hour course or a 4-hour course, depending, and continuing education credits are available for it. And then the provider, after completing this course satisfactorily, can go on to the Health Commerce website and register themselves as a provider of medical marijuana. And this is the same website that we're familiar with using for checking the PDMP or iStock, which is what we use to check prescriptions of controlled substances. Once the provider is registered, this is what they're from their side, the navigation screen looks like. You'll end up with this icon over here, MMDMS, which is the medical marijuana program. So if I want to register someone as a provider, I click on this icon and it takes me over here to this screen where I can view my patients and certify them. The law stipulates that you have to have a qualifying condition and then an associated condition or symptom. The conditions that were allowed were these here on the left. You'll see that a lot of them are neurologic conditions, also HIV and AIDS, PTSD, substance use disorder, and of course, cancer, inflammatory bowel disease as well. And then you have to have some symptom associated with these conditions. So for example, it could be any combination of those two. So if you have chronic pain, that counts as both. If you had cancer and you had nausea, then that would be okay. If you had AIDS and cachexia, that any of those combinations is fine. So you can then choose to select the product that you want to recommend to your patient, but from the provider side, it's not similar. It's not exactly the same as writing a prescription for any other medication. So when, if I write a prescription for medication, typically I say, okay, I'm giving X medication. It's going to be 30 milligrams twice a day, and we're going to dispense 60 pills for the month, and there's 3 refills. There isn't that kind of specificity here in this system. The provider can choose to limit the access of the patient or try to limit the access of the patient to certain formulations. And the initial Compassionate Care Act does stipulate that any recommendations or limitations the practitioner makes should be binding. But I think most often, and what most providers do, is this per pharmacist consultation, which is essentially just saying that I am giving access to the product, to the program, to the patient, and that they are going to have a consultation with the pharmacist at the dispensary as to what product they ultimately want to use. I do know providers who do a lot in trying to specify exactly what the patient should take and how much. This is very complex to do from the provider side, because and you'd have to back in, reach the stipulation each time on the registry if you want to be that kind of careful about restricting your patient's access. So I tend to just default to this per pharmacist consultation. Then what happens is this form, I can print out the form for the patient. They have some instructions there that they have to follow. They should log into an online system and register themselves. They need to have a photo ID. If they have a driver's license, it would be linked automatically to that photo. If they don't, then they have to submit a new photo. And then also they have a way of patients doing this. If they don't have access to a computer, they can there's a phone number there that they can call. That's also really helpful for patients who just get confused by the computer system. It's not the most, from the provider side, it's a pretty user-friendly interface, but from the patient side, it can be quite confusing. So I just always advise people to call the program and ask for help if they need it. Okay, so what different kinds of formulations are available in the program, and how can we advise our patients? So in general, the formulations come in 3 general ratios. So there's high THC to low CBD, then the opposite, high CBD to low THC, and then you can have an equal balance. In addition to the CBD and THC ratio, you have to choose the route of administration. And there are 3 general routes of administration. So there's a vaporized or inhaled form. The duration of onset there is 30 seconds to 2 minutes. It lasts about 1 to 2 hours. And some of the drawbacks there is that it requires a vaporization device. So they are available. They do sell at the dispensaries, these sort of vape pens, and there has not been any report of adverse health effects specifically from the vape pens that have been part of the New York State medical marijuana program. However, out of an abundance of caution, New York State has, while they're still allowing those products, they are recommending against their use because of the potential health effects. The other vaporization devices that are available are these volcanoes. So it's a machine in which you can place a pod of the product, and it creates a vapor by heating it up to below the combustion point. So you just get this vaporized product that is safer. The drawback of that is that it can be very pricey for patients because the volcano can be expensive. The second form that we have is the transmucosal form. So this is usually some kind of a tincture or a spray, and patients can put it inside their cheek or underneath the tongue. It usually has sort of a medium onset of action and a medium duration of action. It's important that patients be counseled not to swallow it, because if they do, I mean, nothing bad happens if they swallow it, but if it doesn't get absorbed through the mucosa, then it will have much less effect because it essentially becomes an oral admission if you swallow it. An oral admission is also a perfectly reasonable way to take the medical marijuana, but it has different properties. So it has a much slower onset of action and a much longer duration of action. And it's also subject to first pass hepatic metabolism. And so that means that the dosages required are much higher in the oral form. So patients need to be made aware of this, that it takes longer, specifically because sometimes what has happened is people will take more than they should because they don't feel any effect of it. And it takes a long time to start coming on. And then they'll take more. And by the time that they realize that it actually did have an effect, they've taken more than they intended to. So education is really important. So currently, at least under the medical program, the dispensaries really kind of control the process from growing of the cannabis product all the way up through processing, manufacture, and ultimately sale. So it's like a single entity. It is a very tightly controlled industry. So all of the cannabis plants, marijuana plants that are grown indoors. They're genetic clones of one another so that they're exactly the same. And there are lots of different companies that sell them. Maybe this is probably a little out of date now. I think there are a few more now, but around like 5 to 10 different dispensaries in New York State. Most also sell online. The online sale really grew a lot during the COVID epidemic, and they will deliver to registered, many will deliver to registered patients. So here are some examples of the pricing. This is a common question amongst our patients. How much does this cost? And this is very relevant because it's not covered by any insurance, so all of this is out of pocket. And here are just some examples of different pricing from Columbia Care, which is one of the large dispensaries. So the cheapest ones are the ones that are the least processed. So these are the flower. It is a ground up marijuana flower, basically. This is the cheapest, presumably because it's the least processed. So it requires the least work on the part of the dispensary companies to produce it. This is now with the passage of the recreational marijuana laws, they're allowing also whole flower. Before it was just a ground up version, but now they're allowing whole as well. And then you can also see an example of the vape pen here, which is currently not recommended. And then also oral tablets and tinctures. They also sell lots of other different kinds of formulation, lots of topicals. And then here are a few other forms. So this is an example of the pod and the volcano vaporizer machine. There are lozenges that are made. There are sprays that can go in the mouth. And then also more recently, there have been these powders For people who want to take it orally but don't want to swallow a pill, it's a powder that they've engineered to be able to be dissolved in water, so you can make a kind of tea out of it. So those are all the products that are the state approved medical marijuana products that are grown from the marijuana plants. But we also have lots of hemp derived CBD products, and this is a very different industry. So hemp is grown on a regular kind of farm. It's outdoors. It's less regulated. It's much, much less regulated than our marijuana industries are by the state. And it has some of all the sort of same considerations that you might think of about normal agricultural products. So in extracting the CBD from the hemp, you require a lot of hemp plants to get the CBD out. So the concentrations of CBD are pretty low. And so there's a lot of potential here for things to go wrong. So there can be contaminations with pesticides or microbial contaminants. So the leaves can get moldy, they can be contaminated with bacteria. Hemp is a bioaccumulator, so if the soil has heavy metals in it, it can accumulate and concentrate heavy metals. And then in order to get the CBD out of the hemp, you need to use a solvent, and so you can have residual solvents in your product as well. And so this has led to a lot of variability in quality of the hemp-derived CBD products that are available out there. In your local supermarket or pharmacy or online. A couple of years ago, USA Today published this report from the Associated Press that collected about 350 samples of CBD products that were available online. And this was an intentionally biased sample. So they were products that people had complained about, but they found that out of these products, 128 of them contained things that they should not have. And the majority of that were those synthetic marijuana compounds like spice and K2. And then 3 of them actually contained fentanyl, which is quite a frightening thing to think about. So there's a lot of variability in the quality of products. Fortunately, there is some way that you can tell whether products are good or bad online. One thing that I always tell my patients is that if it's very cheap, it's probably not good. All these products online are fairly expensive. But a more sort of specific way of doing that is looking to see if the products have certificates of analysis. So so this is an example of a certificate of analysis that is good. So what you'll see here is that first, the product is analyzed for its cannabinoid content, and it should have no THC in it. And in this case, this one is a good one. So it has 99.4% CBD, since that's what it's packaged as. There's then a heavy metal analysis over here, and you want to see that the heavy metals are not detectable. And then there's an analysis for microbial contaminants, and we can see that this one had no bacteria or yeast or mold. There is a program to accredit the labs that do this testing. And that program is called ISO 1725. And so if a seller of hemp-derived CBD has an accreditation on their website, a certificate from an ISO 17025 accredited lab, then they're probably pretty reputable. But you also want to see that they are reproducing that certificate every so often, and that it's not just one certificate from the distant past. There is also a body called the US Hemp Authority. It is an industry self-regulation group, so it's not like a federal oversight body, but it is at least a group of people within the hemp industry that are trying to set a certain standard for production. And so they have very transparent standards. You can go online and read all of what they require in order to have their sort of seal of approval for a particular company. Dosing is also a very common question that patients ask, and it's kind of a difficult question to answer because a lot of the research that has been done on the uses of marijuana has not been done specifically on the formulations that are available. And I'll highlight that as I talk about some of the research in the next couple of slides. So if I don't know that the compound is even efficacious for a particular indication, it's very hard to then say, what dose do I recommend? So usually what we do is try and recommend the lowest possible dose, and then to have people go up from there, which seems to be the safest route. We have the efficacy, and particularly with CBD, this is tricky because the efficacy of CBD alone without THC has not been shown for most disorders. So most of the time when medical marijuana has been tested in research, it's been tested in its whole form, THC plus CBD plus whatever entourage compounds are in there. So it's hard to say how much CBD someone should have or THC on its own. A notable exception to this is epilepsy, because CBD has been very well studied in epilepsy in rigorous clinical trials. So we know how much CBD people take for that. And it's an oral formulation. So we can kind of extrapolate a little bit that at least that would be, a safe dose. So for that particular drug, which is FDA approved, and the trade name is Epidiolex, it's a plant-derived CBD, their starting dose is 2.5 milligrams per kilogram BID. And so that means an 150-pound person would take as a starting dose about 175 BID. So that's a kind of common oral starting dose for folks. People will take something like 150 twice a day, maybe 200 twice a day, something in that general range. We don't know what the exact translation from oral to transmucosal or inhaled is, but we do know that the doses are much lower. There hasn't been a lot of pharmacokinetics or pharmacodynamics comparing those two things precisely to one another. But sort of a general range is that with a transmucosal or inhaled route, something like 5 to 30 milligrams more, as opposed to this sort of 150, 200 milligram range. So significantly smaller. And the CBD products available online, kind of like the New York State products, are also quite expensive. So these are just some examples that I pulled off the internet of a 60 milligram per ml bottle of oil was $164. And then these capsules, 30 capsules, $44. So not trivial for many of our patients. Then we have our pharmaceutical cannabinoids is our last category, and I'll touch on these just briefly. We have dronabinol, which is FDA approved for the treatment of nausea. It's an antiemetic and an appetite stimulus. We have nabilone, which is quite similar. And then we have these CBD, pharmaceutically derived compounds that come directly from the cannabis plant. So they're the natural ones. Nabixamol is a plant-derived extract that has both THC and CBD in a 1-to-1 ratio. It's not available in the US. It is available in Canada and throughout the EU. And it's indicated as a non-opioid analgesic and muscle relaxant there. And then we have in the US cannabidiol or Epidiolex, which is a plant-derived CBD only formula, which was FDA approved a few years ago now for seizures. And they studied it particularly in two rare pediatric epilepsy conditions, Lennox-Gastaut and Dravet syndrome. And so the indications have been just for those two syndromes. So I'm going to switch now and spend the last bit of our time talking about cannabinoid research in the US. And I'll start just by stating some of the barriers. Since cannabis is this Schedule I controlled substance, the research is limited by that. It is very tightly controlled and tightly regulated and has a lot of regulatory hassle. So there's just a lot of barriers to get through if you want to do research on cannabis. All cannabis used in research currently comes from the government, from a single grower. There has been legislation in the works to try and expand this, but the last time that I checked in the past couple of months, it hadn't really gone anywhere. So sort of the irony of all of this is that we can recommend these products in New York State, but there has been literally no research done on those specific products because it's illegal. And so when you recommend them, you really have to sort of think about how comfortable you feel extrapolating from the research that's been done to the particular products that you have available. So by way of an overview, this is the research that we do have available. Of course, there's lots of research on the commercially available FDA-approved products, because all those have to go through the regular FDA approval process. So they have randomized, large, controlled trials. There's research on cannabis itself. The areas in which there's been the most research have included neurologic disorders and also cancer, chronic pain, and HIV. A lot of these studies are very short. So if the investigator is studying smoked marijuana, they can't just hand it out to the patient and say, okay, you take this home and take it 3 times a day and we'll see how you are in 2 weeks. It has to be under tight supervision. And so you can imagine that those studies are laborious and expensive because you have to do them in the hospital and have a place where people can smoke marijuana in the hospital. But longer term studies have been done outside of the US where the regulations are different, and then also on some of the other products, particularly Nabixamols and Epidiolex. And CBD research is growing, of course, because that is now much more feasible to do with the new laws in place. So this research has been summarized up until 2017 by the National Academies of Science, Engineering, and Medicine. And this is a very long monograph that contains basically all the research on medical uses of marijuana up until 2017. It's available online. You can read the whole thing. The highlights, though, from the whole monograph are here in this box, and I'll just read them out. In adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. In adults with chronic pain, patients who are treated with cannabis or cannabinoids are more likely to experience a clinically significant reduction in pain symptoms. In adults with multiple sclerosis-related spasticity, short-term use of oral cannabinoids improves patient-reported spasticity symptoms. So they phrase it this way because it improved symptoms in the study, but not signs. So when you do a neurologic exam looking for spasticity, that was not changed. And then the caveat here is that for these conditions, the effects are overall modest. And for other conditions, there's not enough information to assess their effects. Now, an important caveat is that the epilepsy studies came out in 2018, so they were not included in that monograph. Undoubtedly, they would have been because they were very high-level studies, so I'll just include them here. So there are 2 studies quite similar that came out in Lancet and New England Journal of Medicine, one in mid-2017 and one in 2018. They both looked at these rare epilepsy syndromes that are apparent in children, and they're not just seizure disorders, but they're developmental disorders. So these children can be very impaired. One looked specifically at Dravet and one at Lennox-Gastaut. And in both cases, the addition of cannabidiol to whatever standard epilepsy treatment the child was taking already reduced seizures significantly, but also did lead to more adverse effects. And so these studies were considered sufficient to lead to the FDA approval of this medication for the treatment of epilepsy in these conditions. Specifically with regards to people living with HIV, which is a large population that I treat, there was a systematic review conducted in 2012 looking at the effect of any kind of cannabinoids on any kind of disorder in HIV. They found some methodologic problems overall with a lot of these studies, that the outcome measures were variable, that there was trouble with blinding, which is not too much of a surprise. Like the patients would know, even if you gave them a placebo marijuana and a real marijuana, you can imagine that it might be easy to tell what it was that you got. And overall, they concluded that the evidence for a substantial effect on morbidity and mortality in HIV is currently limited. And I think that that is pretty fair to say that the state of the literature is quite similar today. There's been a little bit more focus on chronic pain in general, and then also specifically in HIV. In HIV, this is focused on neuropathic pain, and these are 2 just example studies of this. Both were quite similar in design. They looked at patients who had HIV-associated peripheral neuropathy and pain related to that, which is typically neuropathic pain occurring in the feet. And they randomized them to receive smoked cannabis versus a placebo cigarette. This was administered 3 times a day for 5 days. So as I alluded to before, these are usually short studies because of the logistical challenges. And these investigators in both studies were interested in the acute effect of the substance on pain. So not so much a chronic effect of cannabinoids over time, but whether they could relieve acute pain in the moment. And both of these studies showed that there was a positive effect on acute pain, at least in the moment. In HIV specifically, there's also been a significant amount of literature focused on cachexia and wasting. This is arguably, a lot of this literature is a little old at this point, and certainly cachexia and wasting is not as much of a problem among our patients living with HIV today as it once was. In fact, with extending lifespans and increasing metabolic disorders, in fact, our patients more often now struggle with obesity than with weight loss. But regardless, there were some small studies looking particularly at smoked marijuana for cachexia and HIV, and then some larger studies looking specifically at dronabinol, which is a pharmaceutical version. There's also been specific studies looking at patients and why they report using cannabis or cannabis products to treat their symptoms. What do they think that they get out of it? So this was a survey conducted in 2005 that looked at 523 participants, and 27% of them, and they were all people living with HIV, 27% were using cannabis for some kind of medical symptoms by self-report. And you can see what those symptoms might be. Obviously, they're not mutually exclusive because they don't add up to 100, but patients were reporting that they used it for appetite, for pain, nausea, anxiety, specifically nerve pain, depression, and then paresthesia. So this probably falls into, again, neuropathy kind of symptoms. And this rings fairly true to me also in terms of what patients come to me for, what kind of symptoms they hope that are going to get better with medical marijuana. As a side effect, 47% did report that there was some memory deterioration. So the other area in which there's a good amount of literature supporting the use of cannabinoids that is not related to HIV is in chronic pain. And here's just a sampling of a couple of different clinical trials looking at chronic pain in different patient populations. So the first study, 66 patients with central pain related to multiple sclerosis were treated for 5 weeks. All of these studies, by the way, are with the Nabixamol's product. So this is the product that is plant-derived CBD and THC balanced and is not available in this country. This particular product is not available in this country, but is quite similar, at least, to some of the one-to-one balanced products that are available through the New York State Medical Marijuana Program. So this one study did show a good effect on central pain related to MS. The second one was a study in neuropathic pain with allodynia, which is like a hypersensitivity to touch, which was helpful. This last study here also had a positive outcome, but this one did not. And I pointed out because it was a cancer pain trial where they looked at people who were already on opioids, and they did not find an additive benefit for cannabinoids. But again, these were probably already pretty refractory pain patients if they were already on opioids. So a little bit of some mixed findings overall, but enough that the NASA monograph did think that the evidence overall supported the use of cannabinoids for pain. So in addition to looking at the potential benefits of cannabinoids, this monograph also looked at the risks. So they specifically focused on 10 domains of risk that are listed here: cancer, cardiometabolic risk, and others. Unfortunately, they found that the data was insufficient in many areas to make a clear comment, but there were areas that they felt like there was enough to either say there is a clear association between cannabis use and an outcome, and then a few areas where they said that there was enough evidence to argue against an association. Some of these are kind of obvious, like cough and phlegm production, and that was with a smoked version. Low birth weight and pregnancy, and so we are certainly very cautious with our patients who are pregnant. I do not, my patient population is such that I don't actually run across a lot of pregnant women, but I think the general practice is not to enroll pregnant women in the medical marijuana program unless it's a harm reduction kind of move. Like, for example, the person is using cannabis out on the street anyway, and the practitioner feels that by giving them access to the medical marijuana program, they will at least reduce the likelihood that the person is getting contaminated substances from the street. Schizophrenia and psychosis is an interesting one, and I'll tell you a little bit more about that in a moment. And then there are some things about, maybe worsening of psychiatric symptoms that may pre-exist. By the same token, many people use medical marijuana and say that it treats some of their psychiatric symptoms. So it's hard to know what to make of all of this. These two were reassuring that there was some evidence against the fact that cannabis use would cause head, neck, and lung cancer, obviously a major concern, and the development of depression, anxiety, and PTSD in people who did not have it already. They also described some risk factors for developing problematic use, and those are listed here: male gender, cigarette smoking, initiating use at an earlier age, heavier use, and pre-existing depression. So again, all these are associations, so not necessarily clearly causal, but associations that were seen in the data. So there is an entity called cannabinoid-induced psychosis. So people can get psychotic symptoms from using cannabis. It's probably just related to the THC rather than the CBD, which tends not to cause many psychoactive effects at all. There are risk factors for this. It's probably more common in people who have a predisposition to psychosis or have a history of it, or a family history of it. And there are probably some genetic susceptibilities as well. That being said, people who have, so if I encounter somebody who has a history of either schizophrenia or some kind of psychosis related to a mood disorder or substance use disorder, I'm very cautious about recommending medical marijuana to them. I only will do it again in the context of a harm reduction kind of situation. So if the person is already using marijuana on the street, to my mind, it's safer to get the product from the program if they can. So at least we know it's not contaminated with other substances. Particularly these days, we worry about contamination of most drug supplies on the street with illicitly manufactured fentanyl, which is very dangerous. So that's sort of my approach anyway to patients with psychosis history. So that's my last slide. I'll just summarize a bit, and then we'll have a few minutes for any questions that you might have. So we've covered a lot today, starting with the idea that cannabis has been around for thousands of years and used for various medicinal purposes throughout that time. And despite significant regulatory barriers that are present in the US, there is a fair amount of research out there about the efficacy of cannabinoids for different indications. The strongest data are probably for epilepsy, and that's CBD alone, not THC, and also chronic pain, anorexia as an antiemetic, and then also for the symptoms of spasticity in MS. The evidence for other indications is weaker. Doesn't mean that it's not effective, just that there isn't as much supporting data. The safety profile is in general favorable, but we have we take some pause in pregnancy in patients with history of psychotic symptoms or family history. The caveat with our efficacy studies is that the specific preparations that we have available in New York State for our patients have not been studied really at all, because this is currently illegal. So we have to, as providers and pharmacists, decide how comfortable we feel extrapolating from the literature that does exist on different formulations. The products that we currently have available in the medical marijuana program are all derived from the cannabis plant, and now there are actually parts of the cannabis plant that are not processed that are also available, the flower. They have two main components, THC and CBD, as well as numerous entourage compounds, which likely or may have active properties, but they're just simply less well studied. We know that THC is the psychoactive one, and it has that effect because it binds the CB1 receptor more tightly, and that's more expressed in the brain. The process of becoming a registered provider and registering patients is pretty straightforward and is all done online, and prescribing or recommending of product should be done as part of a therapeutic relationship, similar to any other medication, and be characterized by regular follow-up and an ongoing relationship. So I will stop there for any questions that you may have. I think we have about 5 minutes if there are questions.
Thank you so much for that presentation, Dr. Albertson and Pat. Once again, if you guys have any questions, feel free to enter them in the chat. I'll start off with the question, and being that we're pharmacists and we see this, or we'll see it quite often, is there a resource that you could recommend for us in terms of just kind of screening for drug interactions and kind of where to find more information?
That's a fantastic question. You know, I don't know of a good resource for that, and I've been asked that before. There are potential for interactions with, particularly with the oral compounds, because of the first pass metabolism in the liver. But as far as I know, that it isn't well studied enough that it's like compiled in any one place. And the last time I checked, most of the kind of standard like drug-drug interaction tools don't have like a place to put that in. So it would be a really great resource if one could be developed. But I think there's going to need to be more research done on like the pharmacokinetics and dynamics of the various cannabinoids to know that. It's kind of the same problem with like a lot of natural products. It's like hard to know where to find that.
Yeah, thank you for that. Another question is there a specific brand that has kind of good quality control or some kind of certificate of analysis that's usually provided?
Yeah, so in the New York State program, any of the dispensaries that are, so you can go to the New York State website. The medical marijuana program has actually a pretty good website that's hosted by New York State, and it will list all of the dispensaries that are legal and registered in New York State. And any of the dispensaries that are registered to the state have to meet very stringent criteria. So all of their products are very standardized with regard to like the milligrams that they contain and the quality. So that is not a concern. The concern would be with the hemp derived CBD products that most people get online. And in that case, I usually recommend that my patients go to the US Hemp Authority website, because they at least list the companies that they have. I think they call it some kind of a certification program. And while it is an industry sort of self-watch group, which you always have like a little bit of suspicion about, it's better than nothing. And so that's how I advise my patients, at least with the CBD products.
Great, thank you for that. A few more questions coming in. Using oral capsules for appetite stimulation, there were reports that this only worked in patients who smoked the product and got munchies. Could you provide some further comments about that?
So that's a good question. So the oral products that are like regular pharmaceutical ones, like Marinol, right, or Dronabinol, clearly do work as appetite stimulants. I mean, they went through randomized controlled trials to get approval for those things. Whether though it's an interesting idea whether there could be some like local effect of cannabinoids that would act like on the GI tract itself, and therefore like route of administration would be important. I'm not aware of literature that says that, but I think a differential between eating and smoking that might be important is just dose. So, you know, if you ingest a cannabinoid, the amount that you have to take to have an equivalent effect is just much higher. So maybe as an appetite stimulant, the smoked version might be more effective just because you don't need as much. And so people are getting a higher dose effectively. That would be my guess.
Great. And one question, just clarifying some terminology. So in the beginning, you had defined marijuana as any product with greater than 0.3 THC, anything not hemp. So is marijuana an official term, or is cannabis the official term?
So cannabis is the umbrella term, right? So the name of the plants like the botanical name of the plant will have the word cannabis in it, like cannabis sativa. And then marijuana versus hemp is more of like a legal kind of classification. Although the word that's how the government uses it anyway, although the word marijuana has been around forever also. So cannabis as an umbrella, and then hemp and marijuana under that umbrella.
Great, thank you so much for the presentation and all the Q&A. At this time, I will announce the CE